How wonderful is it that we're starting with caregiving today? I'm pretty thrilled. By caregiving, I mean the unpaid and generally untrained family and friends who take care of people in their homes, in the home of the care recipient. Economists call this informal care to indicate that there's no formal market for this care. Okay, disclosures. What? Okay. I'm going to start with a case study, not a standard economics class, but I want to motivate the importance of caregiving. So part of my past research has been to understand why people do and do not plan for long-term care. I live across the country from my parents and my place of birth, and I let my parents delay the long-term care discussion until they were 70. They kept putting me off. I gave them annual warnings, and the conversation started out okay. I started with, in case anything happens to you and you need help, it would be really helpful for us kids to know what you want in the future. My mom just immediately started crying because she and we all expected my dad to die first. He acquired type 1 diabetes at age 43, and despite tight blood sugar control, quitting drinking at 65, and being active volunteering as a construction worker for Habitat for Humanity and Catholic Charities, we just expected this order of events. Also, my mom finished her last marathon at age 70, so he had a lot to compete with. Dad had paid his way through college with construction and longshoreman jobs. He was proud of his union card back then, and that he was the first in his family with 9 siblings to attend college and finish. He got the dream desk job as a lawyer, and yet he was always happiest working outside with his hands. After patting my mom's leg, my dad said he would really want to remain at home with home care, paid home care if he needed help. If he lost his memory, though, he would like someone to just take him out back and shoot him. I said, Dad, no one's going to be doing that. And he said, well, just put me anywhere. I don't want to be a burden on you and Mom and the kids. I'll do what you tell me to do. You're going to be in charge. I always knew that I was the one who was going to be in charge. My sister had intellectual disabilities and my brother lived in town, their town, but I was, as they saw it, and many of you in this room are probably in the same role, the responsible one. My mom then said, well, if Dad dies first, I want to move it to North Carolina and live with you and George. Okay, outline. I'm going to give you the landscape of caregiving. I'm going to talk about the economic models we use to address caregiving, and then talk about some directions that we can take both in a healthcare system and in applied research that focuses on policy remedies to think about how we can better support caregivers who are facing taking care of a family member with Alzheimer's and dementia. Okay, latest estimates are that there are 24 million caregivers of older adults. So this comes from the National Health and Aging Trends Study and the National Study of Caregivers funded by the NIH and Jennifer Wolf's team. And of those 24 million caregivers, we have 75 to 95% of older adults that are living in the community relying on family caregiving, unpaid care in the home of friends or family. Disproportionate effort comes from the dementia caregivers. That comes as no surprise to people in this room, I'm sure. Caregiving is most intensive to those older adults living with dementia. And among the caregivers, the spouses and the daughters and those who live with the care recipient are the most intensive. John Phillips already shared this amazing new result from the USC team led by Julie Zissimopoulos and Dana Goldman. There are 5.6 million Americans living with dementia, and I just want to highlight a couple of things that relate to caregiving. This study includes very comprehensive calculations of what are the costs or what are the value of the care role provided by these unpaid persons. Not only do they estimate the informal care hours and the value of that time, and again, value of the time is a real issue in the methods and using the replacement cost methods, opportunity cost methods, and yet they did calculate that. That's common to be included in a lot of projection models. But they also went farther than that, and they understood and calculated the foregone earnings that caregivers face, as well as the quality of life losses, not just to the patients with dementia, but to the caregivers themselves. The other thing I just want to note is that medical care and long-term care are both big components of Alzheimer's care, and medical care is twice as much in this estimate as long-term care. So we need to think about both when we think about dementia, although I'm really going to be focusing on long-term care today. With this huge prevalence and high cost, it's important to note too that we have a real underinsurance problem. Long-term care services and supports are not covered in general in Medicare, and only 20% of older adults are estimated to have long-term care insurance. Medicaid is 10% of older adults. Private long-term care insurance is 10%, but falling. That market's really imploding. And VA offers 1% of coverage. So this is one of the biggest expenditure risks that people face. Well, what is the context for policy supports for caregivers? In general, there are few supports at a federal level for caregivers. The Older American Act does have funding, $150 million a year, goes out to the states. They fund caregiver trainings, occasional respite care, and other features, but really this is $3 million per state. So thinking about that, the 5.6 million people with dementia, 24 million caregivers, money doesn't go very far, although people do the most with what they have at the local level for sure. Since President Bill Clinton ran for office and I started studying caregiving, there have been federal tax credits proposed and never passed. There's a current one called the Credit for Caring, which is a non-refundable tax credit introduced to Congress in March of this year, and the outcome of that is unknown. And finally, there's been momentum at a national level and a law that passed that required the establishment of a national caregiver strategy. That resulted in over 300 recommendations to expand caregiver training, job employment and job supports, et cetera. And yet that's an unfunded mandate. This map on the right is from a study that Kate Miller did in Milbank Quarterly that shows that how states are aligned with those recommendations of the RAISE Act. And what you see is there's a lot of variation that matters where you live. Excuse me. And additionally, Medicaid waiver programs are key ways to support home and community services. Thank you, Kofi. And what we see here is that little red circle, it's minuscule, I know you can't read it, shows that compared to the top row, which is showing the level of growth in expenditures in the last 20 years, home and community-based service funding, there's been a huge increase in supports to caregivers within waiver programs, but it's still a very small amount. Almost every state now, 47 states offer supports in the Medicaid waiver program to caregivers. In this absence of federal and scattered state policies, we look to indirect policies to see how caregivers are impacted. And these are some examples of what researchers have done to understand what are the spillovers of these indirect policies: ACA Medicaid expansion, state paid leave, tax laws, disability policy, et cetera. I want to turn to key economic frameworks and how this works in the family caregiving context. Okay, so in neoclassical economics, and Julie, please don't let your eyes roll it back into your head. I'm going to try to keep it accessible. We really assume that individuals make decisions rationally and with full information. If people make mistakes, they can learn from this and correct their mistakes and continue to optimize their well-being or utility moving forward. Let's think about an adult child trying to decide whether they take care of a parent. There's a utility maximization process that's going on over time of the parent and the child. A household production model applies well to the adult children who are considering becoming a caregiver when a care need arises. These children incorporate the optimal health of their parents into their optimization process. They care about their parents. That's why they incorporate health into their utility maximization problem. They choose consumption, leisure, and whether they're going to provide caregiving, but they face a budget constraint. They can use their resources to, instead of providing care, fund some care for their parents, or there's a lot of research on bargaining models so they can help pay for a sibling to provide the care. Meanwhile, the Grossman classic demand for health model applies well to the parents. In retirement, everybody has Medicare, or almost everybody in the US. So the parents are really thinking about investing. The budget constraint is binding, of course, but it's more thinking about what can you invest in your health now, given your health capital, to optimize your health moving into old age. So the parent makes investments in health. They choose their types of medical care, including formal paid care, but they take the informal care from the children as given in their optimization process. We know there are different returns of investment, which is quite unknown on how medical care will produce health and preserve their health. And it depends on the quality of the care they receive, as well as their preferences for care when you think about trade-offs between family care and home health care. In general, what we know is that because everything is the health of the parent is included in the children's optimization problem, and the parents rely on the supply of informal care for their own well-being and optimization process, that these are intertwined, and that the outcomes of the parents are co-produced with the informal care of the children and their choices, which means it's also true that the caregiver outcomes are also co-produced or jointly determined with the parents' decisions. So what are the effects of caregiving on outcomes of the care recipients? This is drawing from only the causal economics literature, where we try to account for this notion that there's joint determination, and we need to address this somehow to mimic a randomized control trial with methods to see what is the true effect of caregiving on outcomes. In general, the picture is really green and good, and for the care recipients. The care recipients have better outcomes, have lower healthcare costs, and lower utilization, both lower long-term care utilization like nursing home and home health care reductions, as well as lower acute care and emergency department care and inpatient care. The bulk of the evidence is in the bottom of the triangle, and there's fairly low evidence in terms of increased health outcomes of the care recipient, but there is strong evidence emerging. What about for the effects of caregiving on the caregivers? Here we have worse health outcomes at the bottom, in the middle, sorry, worse economic status, most of that's coming from labor market changes, and higher utilization of the caregivers. Women in particular have been shown to bear the worst of the work outcomes. They have lower wages, retire too early, quit work, and cannot re-enter the workforce, at least among older workers. Emerging work by Yulia, who you're going to hear about from later, Yulia Truskanovsky, shows that when you look at the full distribution of women working, after a caregiving spell, they can recover their earnings after 10 years. So maybe for the younger workers, there is an ability to recover. There's also heterogeneity, not just average effects, that are shown to be most negative in general. People who are taking care of a parent or a family member with dementia, they have the worst outcomes. And that goes along with the fact that caregiving is quite intense and long duration. I want to point out, of course, there are benefits profiled extensively in different literatures, but in the causal economic literature, in general, the effects are negative. We know from qualitative research that caregivers really gain utility or well-being by fulfilling their duty, paying back parents, supporting the parents' goals, and having closer or healing relationships after the caregiving experience. Though I will note that in one causal study that I was involved in, we found that intensive caregivers compared to non-intensive caregivers have a worse relationship with their care recipient. So caregiving may be okay, but not too much of caregiving in some cases. I want to talk about the neoclassical model and how their mistakes may be made in decision-making. And part of it's because we have problems with full information. Initially, a lot of caregivers and parents who may be getting dementia don't even understand what's covered in long-term care in the US. That is not a new fact, but they don't know that Medicare doesn't cover long-term care. From the caregiver perspective, older workers may not be able to re-enter the labor force. So even though you take on a role knowing what to expect, you don't know some of the negative consequences that I just profiled. Or injury may be happening as a caregiver, and it could be fleeting or it could be long-term. So there's miscalculation and what are the true impacts. And there are lack of alternatives. So that budget constraint is really difficult for people to surmount. That is exacerbated by things like workforce shortages, et cetera. There's a lot of duration uncertainty. People don't know how long this is going to last, when they should trigger their long-term care insurance if they happen to have private insurance, or how long it will take to spend down to Medicaid to cover the care that the family needs. In addition, there are externalities. I think this is really not incorporated into studies yet, and there are things that happen that we need to think about how to incorporate. If I'm a caregiver worker and I'm less productive on the job, that affects my team members, and those are things that we need to think about. What happens when you have to call your neighbor repeatedly to come help, and that person's not really involved? How do we incorporate those factors? And how should preferences be weighted? Preferences change from the person living with dementia and cognitive decline. And there are a lot of ethical and emotional tensions for many reasons within the family making these choices. There's a lot of problems with considering the preference for autonomy and the safety trade-off, and whose preferences matter most. The brain changes that come along with dementia really do cause flawed decision-making. So people change their preferences and they don't think about what is best for the family. Before they had dementia, they said, I'm never going to burden you, and then that disappears. So these are things that we don't really incorporate into our utility optimization models and need to think about more. What about behavioral economics? The standard economic model, as Thaler points out, includes these unrealistic traits, and behavioral economics tries to get at that. They try to address things like loss aversion, willpower. Willpower to me is more interesting and easy to think about in terms of prevention. Preventing, we know we stop smoking, we would prevent bad outcomes later. This applies to prevention and dementia, of course. But things like selfishness, it's really hard to think about selfishness as selflessness in the context of dementia to me. So how can we think about behavioral failures in long-term care planning in the light of dementia? So we know there are many reasons why families don't plan. One of them is that planning can be a luxury, but also before dementia happens, people are biased towards the present. They're worrying about other expenses like getting their kids through college and not saving for the future. Or it's too difficult to think about. It's really complicated. People don't know how much to save, even if they have the option to save, and they avoid these complex calculations. Or they just don't want to think about the future, and they have the ostrich effect come into play. When dementia occurs, I feel like present bias is very appropriate to think about in terms of the person living with dementia. It's really difficult to plan for the future. In fact, people become very focused on the present or the past. In addition, there's a lot of denial, complexity, and planning failures in this arena, and a changing sense of self. There's a disconnect between intentions and actions. And we need to think too more about how do you, as family members, really represent the preferences of the person living with dementia when they have agency in early phases of the disease and they have strong preferences for what they want, but the family may not think that's in the best interest of everyone. Again, this safety and autonomy trade-off, I think, is very difficult to grapple with. I think it's really important to push how behavioral economics can address these pitfalls and think about interventions that would happen upon diagnosis. So in this context, with no comprehensive insurance, several documented negative spillovers of the current system of long-term care to the caregivers, and no signs of a societal contract that invests in alternatives to informal care as the main providers of long-term care, how can we begin to minimize losses and maximize gains for caregivers and help them be more resilient? I want to talk about the health system role and our researchers' role next. First, for the healthcare system. This larger project funded by NIH is really focusing on prevention, and the health system has a huge role in prevention. And it also has a massive role in early diagnosis. Even within the absence of effective treatments right now, there's a huge gain in understanding what's happening for the family members so that they can know what to expect in the future and begin to plan, even if they hadn't planned in the past. We have a basic problem in caregiver research that focuses on the health system, and that we have no standardized, systematic way to identify who the caregiver is in a health system. And this is a very big barrier to extending treatments and trainings and inclusion in the healthcare team for those caregivers if we don't even know who they are. I've written about this from my own personal experience, that caregivers' names are written on whiteboards, and yet we don't know how to contact them in a real-time way. So basic investments in infrastructure could really help healthcare systems identify and equitably extend services to caregivers, to give them things like the CMS new guide model that is a comprehensive way to better support aging in place for people living with dementia and supporting the caregivers through trainings. Also, CMS offers caregiver reimbursement for caregiver training. If we can't identify people, it's going to be the same savvy people to self-elect themselves for caregiver supports, and not the people who are most at risk of bad outcomes. What's the researcher's role in terms of informing policy? I do want to see more theoretical models in economics that better incorporate this interdependence of caregiver and care recipient utility, and the uniqueness of dementia in particular. The anguish to caregivers and lack of choice and trade-offs are understudied. This emotional toll. Whose utility should we be weighting more strongly? How do we weight the utility of the healthy spouse who is affected by all of this? Whose preferences matter most? And how can we have behavioral economics apply in dementia care and caregiving to better support the caregivers? It seems a lot harder than putting a different size plate for portion control or putting stairs in the front of a building. But what could we do on early diagnosis to make some things be default services offered to people living with dementia? As I said, caregiver policies are still very rare. So we need to keep studying spillovers. You're going to hear about health policy and payment design later today. I want to talk about one feature of health policy, which is HCBS expansion, home and community-based services expansion, as a caregiver support policy. There are other features listed here, public health initiatives and labor policy, that are vital and ongoing areas of research for myself. I mentioned this role for surveillance. We need to know who the caregivers are and where they are, and update this information to reach them. In terms of labor policy, what do state paid leave policies have? What does flexible work mean for caregivers? But in the interest of time, I want to follow through on HCBS as a caregiver support policy and give a couple examples of studies. The first one looks at potential caregiver outcomes. With Gopi, Goda, and Norma, we looked at whether holding private long-term care insurance from older adults changes the behaviors of adult children who are the potential caregivers. Does it make them less likely to be a caregiver? Does it change their work behaviors and where they live? We grappled with this causal inference need by using an instrumental variables approach, and we found that private long-term care insurance helps the potential caregivers, whether the adult child ultimately becomes a caregiver or not. The adult children of parents who were invoked to buy long-term care insurance due to state price subsidies were no more likely to become a caregiver than those who didn't buy the long-term care insurance, but they were more likely to work full-time and to not live with their parents. So there are these spillovers to the economic well-being of potential caregivers that we need to include in the calculations of the effects of something like a price subsidy program for long-term care insurance, and thinking about the value of covering long-term care needs. You may ask yourself, well, how is this relevant? That's 10% of people have private long-term care insurance, and they're doing the best economically. But Karen Shen has found in a Medicaid population similar findings, that the adult children are freed up when their parents are covered. So this could be a really important implication for covering those most at risk of negative economic outcomes from caregiving, those without resources going into their role. That's looking at potential caregiver outcomes. I want to talk about the effects of HCBS expansion on care recipients. The second study is with Tamara Konecka, who's here, and led by Norma Coe and Anirban Basu, where we looked at the causal effect of family care, formal care, and a combination of both on the health outcomes of the care recipients. We also use an instrumental variables approach. And what we found is that the care team matters for care recipient outcomes. Receiving both formal and family care led to better self-rated health and lower depressive symptoms than those who received only family care. So adding formal care is a promising policy remedy for the outcomes of the care recipients. Receiving formal care alone did not affect care recipient outcomes on top of receiving, as opposed to receiving family care only. These findings combined are important to consider as we strive to best meet the growing demand for person-centered, high-quality long-term care in the least restrictive setting possible. How about future directions? We need to dig deeper to understand many questions surrounding home and community services. What is the right mix of the home care team? Why does the care team matter? Is it task specialization? Is it preserving family caregiver health? Why might adding formal care to family care, and why might not the care team matter? Are there too many unmet needs? Is there no net gain in hours of care when you have a combination of care? We need to really understand the monetary and shadow costs and benefits of these components, and how do they vary by the care provider in the home. States are moving to expand paying family and Medicaid waivers, and we have done some also past research in a cash and counseling demonstration that shows that invoking family involvement benefits the care recipient's health outcomes, but we haven't looked at how it benefits the caregivers or whether it harms the caregivers to be in a paid role over time. In general, I would like to see more consideration of both the benefit and costs and combined with family preferences perspectives to truly assess the value of HCBS investment and aging in place initiatives. Aging in place necessarily increases the role for family caregivers. Where else can we go in future directions? We need to use international lessons. Again, with funding from NIH, a team at USC, and many other institutions led by Jin-Cook Lee and Dave Knapp. Dave's here, I think. I saw him over there. This Gateway to Global Aging policy has profiled the long-term care benefits longitudinally since the 90s. In the US, around 25 states are completed and 16 European countries. This infrastructure investment is the purpose of that is to enable causal research in public long-term care policies. Because there's variation in coverage and generosity, we can look at how these systems' effects are on care recipients and caregivers using health and retirement study data and understand what are the most effective policies in Europe or the US, and how can changing eligibility criteria change the outcomes in terms of expanding US long-term care benefits, not contracting. And finally, we need to include the full caregiver effects in long-term care policy reform models. Gopi Goda and I have written about this, and Gopi led this great piece that we wrote in her Brookings website article. We evaluated the Medicare for All proposal that came from candidate Harris in the election, where the estimate was that extending home care to 15 million beneficiaries as a part of Medicare would cost $4 billion. The cost of this proposal bill did not include a single caregiver cost. So what I would like to see, and what I will try to be working on, hopefully with Gopi, is incorporating caregiver spillovers in order to more accurately project the societal benefits and costs of different long-term care policy proposals. This information is vital because policymakers want to have an accurate idea of what happens to public budgets, to the long-term care workforce, to health systems, and to health outcomes of different policy proposals. Thinking about specific applications, this new guide model that's in place, what is the actual cost to that model if we increase aging in place and think about caregiver costs and benefits to such a policy? Okay, to finish the case study. 7 years after that long-term care discussion, it was clear that Dad had dementia and he got an Alzheimer's diagnosis from his providers. We entered an era of him refusing to consider the future, withdrawing from his best friends, getting lost driving, having lots of volatility in blood sugar control, and then eventually multiple falls and a cascade of ED and hospital visits. Mom frequently called my brother and neighbors to pick my dad up. He broke a vertebrae from a fall down wooden stairs, which caused an incredible amount of pain. Meanwhile, my brother was laid off and didn't feel like he could go back to work because of all the emergency calls coming. I traveled out as often as I could and monitored blood sugar from afar, which really irritated my dad, who was proud that he had all fingers and toes after so much time with type 1 insulin-dependent diabetes. Dad found ease and calm only when my mom was at home. He found joy in his youngest granddaughter's visits and watching bluebirds at the backyard feeder from his chair. Here he's listening to a new song that my son had written and that I had let him listen to. I finally secured regular home care, and he gave them a hostile reception each day. Each day it was a surprise to him that they were there again. So much so that it was hard for my mom to leave and take a break. Dad called me untrustworthy 1 minute for hiring these aides, and in another said he would do what I recommended to protect mom. He hated the interruptions into his home. He continued being a doer, loading and unloading the dishwasher, and slowly raking leaves, even when it meant he would fall down. After a final fall in his bathroom put him in the hospital, Dad died 10 days later. In that final hospital visit, we could finally just stay with him and not be hounded to leave. Meanwhile, we waited and waited for a hospice bed to open up. And in the back of my mind, that's a strange thing to hope for a hospice bed to open up, right? In the back of my mind, I was thinking, how in the world are they going to afford $800 a day in this home-based type hospice facility? It didn't take more than 3 hours after he arrived at that facility when it opened up for him to die. And yet my mom was comforted that it was such a beautiful place and he didn't die in that cold, sterile hospital. I know this experience is unique and is not unique. 2 years later, I'm still processing his final 3 years as a daughter and as a researcher. What did we each optimize? And at what cost? To my mom, to my brother, and even to me. What would I have changed with better policies and systems in place, or with better information? Or what would have happened if my dad had seen the cost on my mom and brother? I really do think research can help and improve the lives of people living with dementia and the caregivers who support them. And these are just a few ideas that I have as I close out. When possible, as researchers moving forward, let's try to evaluate caregiver effects and care recipient effects. Sometimes this has to happen in tandem because there aren't data sets with both outcomes. Please think about adding person-centered outcomes to economic outcomes so that we understand the full benefits and gains, benefits and harms potentially, measure harms of different comparative effectiveness outcomes. Engage clinicians who understand clinic flows and constraints of delivery. I have benefited very much from working with interdisciplinary teams, and that includes engaging with qualitative experts to talk to families. Thinking back to that long-term care insurance project, we understood why people didn't plan. They didn't want to burden their children, but they didn't have resources to plan. But knowing that they didn't want to burden their children is one way to think about how we can have marketing campaigns or other initiatives to have people increase their planning so that they won't ultimately face causing burden to their children. I never would have done qualitative research without engaging other colleagues in my research. We need to keep evaluating general caregiver samples. We can't always just only look at dementia because we have sample size problems. And yet we can still make inference about what happens to dementia caregivers, even looking at general caregiver populations. Besides great research that's emerging using SIP, using BRFIS, using CPS, we really need to think about how we can expand and have firm level data to understand caregiver effects and other unique data sources. Having caregiver outcomes linked to claims is a rarity. And that would fill gaps in our understanding of some of the impacts of caregiving on caregiver health outcomes and utilization and cost outcomes. All right, that's it. Thank you.